I'd like to welcome Lynn Williams. So Lynn is a patient who has multiple myeloma and is going to share with us her experience. So she was diagnosed with multiple myeloma at the age of 43 and she's now 66. She's had lots of different treatments for myeloma in the past, currently on her 9th line of treatment, and previously had a stem cell transplant, and has only had one type of BCMA-directed therapy. So you've heard about lots of different types of BCMA-directed therapy, but Lynn has just had the one, which is belantamab mafodotin. So we're very interested to hear about Lynn's experience. She's been on and off it over the last 10 years, sometimes on treatment and big gaps off treatment. And this webinar is about quality of life. So we're very interested to hear from Lynn about her quality of life. And also I'd like to invite Fredrik and Han into the discussion as well. So Lynn, welcome to this webinar. We're really interested to hear about your experience. And maybe we could just kick off with just about how you're feeling now and how you think the treatment is affecting your daily life.
Well, right now I'm absolutely fine, really, apart from the eye toxicity that occurs with it. But my quality of life is fine. The way I'm actually having the treatment at the moment is the best I've ever had.
Okay. And when you say quality of life is fine, give us an idea about what you do, Lynn?
Well, I'm retired. I've been retired for 10 years on ill health because of treatment that I had in the past that was rather vigorous and not very pleasant. And I can do most things. Walk, housework, gardening, anything. It's not a problem for me at all.
And you always seem to be busy looking after grandchildren.
Oh, yes.
Right. Okay. And so what's the treatment burden onto you in terms of how often we're asking you to come up to hospital and the impact of that?
At the moment, well, I'm only coming up every 12 weeks. And it's not a problem for me at all because I live in London. No problem whatsoever, really.
Okay. And you mentioned that you were having some trouble with your eyes. Could you just tell us a little bit more about that?
Okay. Well, when I've been on the 12-week process, the first few weeks my eyes are fine, and then they go off. First of all, I can't read very well. I mean, I can't read very well at the moment. I'm actually going through that process now. And also distance. But I just manage it by using different glasses. I have to use intermediate glasses to see distance. It's things like that. And I use magnifying glasses over my glasses when I want to read. So I just manage the situation. It usually lasts for about 6 weeks, but I've just been put on a lower dose. So at the moment, I don't know how long it's going to last. And then my vision is back to normal.
Yeah. Okay. And so you've been on this treatment, as we said, for on and off for about 10 years. Has the way that you've received the treatment changed over this period of time?
Well, the first 2 exposures were clinical trials. So the first exposure was just with belantamab on its own, and I was having it every 3 weeks, and my eyes were pretty bad then. Unfortunately, on that trial, because I didn't really know much about the ocular problems, because I think it was a phase 1 trial, I had to put dexamethasone drops in my eyes.
Yeah.
And that was where my quality of life did fall down, because it caused me to have postnatal nasal drip.
Yeah.
And I had terrible coughing, and because I assumed that my throat was trying to get rid of it, so it was producing lots of saliva all the time. So I ended up with pharyngeal dysphagia. I was choking when I was eating and drinking. So that did affect my life a lot. But it wasn't the thing is, it's not the drug though that was affecting it. It was what I had to do. But that was a big problem. To be fair, that was.
Just to make sure the audience,
Yeah.
you no longer recommend dexamethasone eye drops with
No.
belantamab, but they were found in
Yeah.
that study to not be of any benefit. So
Okay.
just to the audience members, that's
Yeah.
not something that you should be prescribing yet.
No. And on the second exposure, it was mixed. Was it Dream 7 I was on?
One of them, yeah.
One of them. It was with bortezomib
Yeah.
and dexamethasone. And again, I'm not very good with steroids. And it played absolute havoc with my blood sugars. And we did stop that after 2 cycles. And the bortezomib I'm fine with that. I've had that several times before in past treatments, and it does work for me, but it does upset my stomach. So again, it wasn't the belantamab that was the problem; it was things that I had with it. But sorry.
And so I guess, Lynn, just you mentioned the steroids. So
Yes.
you're on steroids now. Do you think?
No, I'm not having steroids at all on this. I'm just having the belantamab, and I'm absolutely fine.
And just to bring in Hang and Fredrik, I mean, you prescribe different BCMA therapies for your patients as well. How does Lynn's story kind of fit with what you see in Australia and Norway?
Well, I can only answer for Norway. Belantamab, I consider it a drug that is more or less without side effects if you disregard the eye problem. And eye problem is very different from patient to patient. Some don't. Some have a very low tolerance for it, especially younger people in maybe they're still working, for instance. And I also think we overdosed it in the beginning by giving it every 3 weeks. So we don't do that anymore. And we have some patients who have no eye problems. So we have some patients who have an eye problem in some period after each dose. Which is sort of very similar to what you're saying, Lynn.
Yes, that what happens to me.
How much it affects each patient is very different. But I think my impression is the same as in the studies, that very few patients need to stop because of these ocular events. It's like 5, 6, 7, 8%, something like that. Most can tolerate it by managing it with delays and a longer frequency and dose reductions.
And Hang, your perspective.
Thank you, Rakesh. I completely echo Fredrik's experience, and also Lynn's journey has been very typical of the type of experience my own patients have had. Like yourself, I've had patients on this drug for more than 7, 8 years on a single dose. One patient had it every 6 months, but usually every 3 months. And I have to say, out of all the drugs I've ever experienced with multiple myeloma, this is the only drug whereby patients actually feel normal in between the doses. It is very important, as Lynn would testify, to acknowledge that the ocular adverse events are reversible. And because we know that they are reversible, it gives us a lot of reassurance. And remember that ocular adverse events are mainly initially when you're trying to find the dosing schedules. Ocular or eye assessment, for me, I only do it in the first 4 cycles to gather the frequency. And then with time, and I don't understand why, at the same dose every 3 months, patients do not get ocular adverse events anymore. Some patients don't and some patients do. But I mean, Lynn seems to be getting ongoing ocular adverse events, but I don't think they are cumulative from my experience. But certainly it's been one of the more positive and predictable drugs that I've worked with.
And I think, Lynn, you'd echo that it is predictable, because I said we were going to adjust your dose and you said please don't because you had something planned one time. So it is quite predictable, isn't it, what happens?
Yes.
You plan your life around it. Is that right?
Yes, indeed, yes. At the moment, I would say that with this reduced dose, I think this is not going to last as long this time. I also went 14 weeks before the last dose as well, because it was over Christmas period. So I think that it will come back quicker than it did the last couple of times.
But you have maintained your responses for quite a long time, haven't you?
Yes. Because once the first time I had it, I went into complete remission for 2 years. I think that's because you gave me quite a lot of it, really. But I did actually say from the beginning on that first trial, I don't think I need as much of this as you're giving me. This would be nice to have
And
in a longer period, which is weird, isn't it?
So important, Lynn. I think we're hearing that from patients all the time, that you want to take a break from treatment, and I think, and you've done that, over the last 10 years, had a break, and then had the treatment again. Now, Lynn, I've got two questions from the audience. The first is, what aspects of the treatment with belantamab have had the biggest impact on you? And these are both positive and negative. So if you think about one big positive outcome and one negative outcome.
Well, the most positive one is that I'm normal, to me, really. Whereas some of the older drugs that I had years ago were awful, and I didn't feel normal, and I had bad stomachs, and the steroids were awful. But this is, it's you wouldn't even know I was having anything, because I go in, I have the drug, and I come home, and I just carry on as normal. There's no difference. The worst thing for me was when I had to have, on the first trial, really, because of the choking. I mean, that was awful. I couldn't swallow properly, and eating and drinking was very difficult.
Yeah. Those steroids.
But that's things that we don't know about, and that's why we do trials. So.
No, it's here, and thank you so much for participating in that. It's very helpful. The second question is around driving, and I don't know if you drive a lot.
I did. I don't. We don't now, so we don't have a car. But I wouldn't drive whilst my eyes were in the situation I am right now. But once I know when they improve and I can see normally, and I would drive then if I needed to.
Yeah.
But I wouldn't drive, because that's just me. I wouldn't drive once I know my eyes have, as I say, gone off.
And I think that's your general guidance. I mean, the question specifically asks if we need to notify the licensing authorities when people commence belantamab mafodotin. Now, certainly within the UK, you don't need to notify them when you start. But if you do feel that your vision has been disrupted, then you are duty bound to tell the licensing authorities that your vision is impaired and you shouldn't be driving. And if you are seeing an ocular specialist, then they will recommend that as well. We've got some more questions if we can just move on. So what I might point this to, we'll start off with Fredrik, and the second question I'll ask Hang. So gosh, lots of questions coming through. Fredrik, what are the most common misconceptions about BCMA-directed toxicities and dose modification strategies? So what do people just kind of get wrong when they think about the toxicities and modifying their dose?
In both ADCs and bispecifics.
Yeah.
So I think it's more wrong with bispecifics than with ADCs. I think with ADCs, it's quite clear that we are able to maintain response with the frequency that people end up with. People usually end up with every 8 weeks, every 12 weeks, even more. And that seems to, in very many patients, still maintain the response for a long time. So I'm not sure that that's a misconception. That's more the conception, I would say. I think the misconceptions goes more to the bispecifics, where I think this is increasingly known amongst sort of experts who do the clinical trials and so. But we see that in all clinical trials, we're starting to use bispecifics less and less frequent. We started to think more about maybe after 6 months of treatment, maybe we have gotten all the efficacy we can get. So I think we have a lot of over-treatment with the bispecifics when we follow the SPCs. I think that's more sort of accepted now with belantamab, that we don't need that. But also bispecifics should be, in my opinion, dosed less frequently, go early to a less frequent dose. And there's also coming up data showing that if you stop bispecifics quite early, let's say after 6 to 9 months, when patients relapse, it doesn't work.
Yeah.
So I think that means that in bispecifics, you actually kill very many of the cells you can potentially kill with that treatment quite early on. So maybe the continuous use you're doing with bispecifics is not making any good for anyone, but it does give a lot of problems with infections in the long run.
Yeah. Okay, thank you. And you can see Lynn's been exposed to belantamab 3 times with relapses in between and responded each time. So it's interesting. And this is a broad question, but maybe a very quick answer to this. What new data would be most likely to change your current clinical practice with BCMA treatments?
I think the new data that we really need is prospective studies of clinical outcome associated with real-world adaptations. Right now, all the data we have are retrospective, are descriptive, and I think we do really need robust data.
Right. So we've just got a couple of minutes left. Lynn, the question for you. Based on what you've gone through, what is the most valuable advice you can give to doctors and healthcare professionals when they're about to prescribe belantamab to their patients? What's that piece of information you wish you would have told me before I started you on it 10 years ago?
I don't know. Please. I don't know, because you don't know how it's going to affect each individual anyway. And I've, in my experience, people who have multiple myeloma have it in so many different ways. I mean, I've never had any symptoms really of myeloma, and other people have lots of symptoms. So it's very difficult to know what you would say, really. I was just pleased you were going to give me something without steroids.
Okay. No, that's helpful. And then the last question, and we can ask this to you, Lynn, as well, was did you get any pain associated with the eye symptoms?
No, just, well, again, because I was putting so many drops in my eyes, various, they got sore.
Yeah.
But not in my body. No, nothing, no pain in my eyes. No, just they got sore and achy.
And I think you've already just answered this question, is that recovery is possible. I think we've seen the data that's been shown, and your experience is that it's reversible, isn't it?
Oh, yes, all the way through. Yes, it comes back.
And someone's asked, did changing your glasses make any difference? I think you mentioned something about that.
Yes, well, I bought some magnifying glasses that I put over my glasses for reading, and I'm just getting to the point now where I don't need them. So I think there's improvement coming. And as I said, I use the glasses I have on now are for computer work, or for a middle intermediate side, and I've been using those for long distance, which improves it. So I just manage with the things I have, because it's such a short period of time. It's only a few weeks.
Yeah.
And then in the overall, and the overall treatment is, it's far better to just go through that with no other problems. I mean, stomach problems and all these other problems that you can get with chemotherapies.
So I think we're at time, and we're going to close. I think the last question was why did we re-challenge Lynn with belantamab instead of a different bispecific? And we did talk about that actually, Lynn, when the bispecifics came up. But I think you were keen to go back onto this because I guess it's...
Well, having just watched all of this, I think I would have a problem with infection with the others. And I don't have any problems with infection. I haven't had any infections at all.
Yeah.
I've not even had a cold.